Great. Thank you so much, Dan. So we will go ahead and get started. I wanted to actually put out some ground rules now because that'll be the stage that I'll be in, the headset that I'll be in when we move forward. First of all, I'm going to go over a lot of billing. I'm going to go over a lot of coding, but I always want you to keep in mind that we code for what we do, and we don't code in order to obtain reimbursement if it doesn't quite fit. So, and that's always been one of the tenets of BIOLES. That's always been something that I've taught. You know, we always are going to try to get benefits for the patient, but sometimes it just doesn't work. So we will do as much as we can. I'm going to give you some tips and tricks. And I know on the Friday session, so hopefully you reserved this same time, on the Friday session, we're going to get into it a little bit more. I'm sure you'll have some specific billing questions, and I'm really waiting. I'm excited to tackle those. If you've never heard me speak, then you will find out very quickly that I am an insurance nerd, and this will come across loud and clear. It's going to be really good to be able to have Dr. Lau with me on this, because my audience typically is the billers and the office managers, and sometimes they don't understand because they just haven't been exposed to the clinical side. I was the same way. So it's really, I love the style of this presentation that will get the billing as well as the actual clinical part. So with that being said, given the ground rules, we're gonna make this for everybody, and we're definitely gonna code for what we do, and we're going to make sure we find the right code for everything. Let's jump into it. So what we have in the industry and in our country for our patients is we have a lot of people that have periodontal disease, you know, from mild all the way up to severe. You know this because they come into your office and they're always asking for help with this. And if you're out in the public for any amount of time, then you definitely have come across people who have this condition and you wish you could pull them into your office and treat them. 40% of the patients that you see have mild to moderate periodontal disease. This information is coming from the Center for Disease Control and Prevention. So this isn't something which should surprise you. This is pretty standard information. I don't know if it's changed very much, but this doesn't surprise me at all. We wanted to focus on the fact that periodontal treatment in your office, you do see the whole range, but you definitely are paying more attention and trying to heal the moderate to severe. So when we go forward, going over some of these procedures, keep that in mind. And of course, the goal is to move them to a more healthy stage. Now, one caveat that I'll give you is that we don't have anything in here about the new periodontal guidelines from the AAP and the World Health Organization. That doesn't mean that you shouldn't pay attention to them, and we'll definitely go over that in the Friday session. So remember that we're going to be moving our patients we're going to grade them, right? And then we're going to be staging them, moving them down the stage to health. So that's something we're going to have to pay attention to as far as documentation. Clinically, I'm not a hygienist, I'm not a doctor, I am a good old-fashioned office manager and billing coordinator, but even I know that the documentation is going to require a good diagnosis and prognosis, and hopefully I'll get you to that point where you have really good documentation. So let's get into it. I am really concerned with documentation in our industry only because when I was consulting full-time, I would go into offices and I would see that the documentation was very lax, was not complete at all. We could not recreate the appointment based on what we saw. And if templates weren't used, then it was really almost a hit or miss. You were rolling the dice whether or not you had the correct information. Now, the good news is we're going to give you the information that you'll need as far as templates. You know, Dr. Lau has always used these in his presentations where he's got everything that you would need for his protocols, and that's what you would put into your notes. So we're going to give those to you, and I'm going to add a couple items to it when we get there. So we didn't address this in the beginning, so I'll just say it now. We are going to give you a copy of the slides. I know many of you are saying, you know, can I get the slides? We'll give you a copy of the slides in PDF form, and that'll come to you at the end of the presentation. For right now, I just want you to focus on what it is that we're going over so that you can implement it when it's time. So my documentation piece, I want you to think about this. When you have the patient in the chair for the comprehensive evaluation and the periodontal evaluation, I'll get to that in a second. When you have them in your chair for a complete examination, hard and soft tissue, what that is the perfect opportunity for you to gather all of the documentation that I, as the insurance coordinator, need in order to get your claims paid. So there's a mantra that I repeat in my classes, my billing classes, which is documentation is going to drive your revenue. And today, more than ever, it's so critical to do that. We know that reimbursement is getting harder and harder to obtain because some of the policies have just become so restrictive. And really, my only way of getting you to the reimbursement is by making sure the documentation tells the story, and I can use that in my appeals. Unfortunately, when I was in offices all of the time, I would try to write appeals and I just did not have the information available to me, and so we would lose many of those appeals. That probably rang true to some of you because I know this is a common problem across the country. For those of you who are joining us internationally, you're probably thinking, wow, I'm glad I don't have to deal with that. It is sometimes a struggle. So let's talk about the difference between the comprehensive and the periodontal evaluation for my people who aren't necessarily clinical. The comprehensive is everything. We're the class, the bite, everything, soft, hard tissue. The periodontal evaluation is the same exam, but with a focus on periodontal, the periodontal condition, signs, and symptoms. And so when you look at it that way, most of you are actually doing a periodontal evaluation, not a comprehensive evaluation. Now, I don't want you to go back and change the world right now, but I do want you to take a look at your systems and see if that's in fact what you think you're doing. So if you are actually doing more counseling with needing periodontal work and you see that there's other systemic issues, their medical history really just leads into periodontal condition more severe, or I'm guessing more advanced, I should say, periodontal condition, then what you've done is actually a periodontal evaluation. And so I want you to think about that because although the reimbursement tends to be the same as the comprehensive because carriers will map that down to a comprehensive evaluation, in your clinical record, what you have done is accurately represented what you did. And so that's why I would really like you to consider whether or not you performed comprehensive versus periodontal. So while you're in there, that's the best time. Patients there, it's a great time to connect with them and really, I guess, instruct them on your way of doing things. And also it's a good educational point. So what I'd like for you to do is make sure that you're charting correctly. I have this down below, but I want to kind of blow this up a little bit because I'm hearing more and more that claims are being denied because the charting is not accurate. And what I mean by that is missing teeth are not noted. So your practice management software actually takes all of those missing teeth that you've indicated and it will use on the claim form, the electronic claim form, it will actually indicate that for the consultant or even the electronic systems that takes a look at it. So please don't skip that step. Make sure that you're charting missing teeth and basically history. So I'd like you to bump that up in priority because it does seem to be something that falls off the radar sometimes. So with templates, and we'll go into it a little bit, with templates, there is a concern among the carriers that people who use templates are abusing them because they will just use the same template over and over again. So the format of the template should be the same, absolutely, but it is to be individualized, of course, for each patient. So I know that you might be in a hurry and you might be, this patient was just like that one, but let's make sure that we have it individualized for the patient record. So when we talk about the documentation, the perio charting, the periodontal charting, the carriers, almost all of them, and the AAP has recommended once a year periodontal probing. And so that means a complete periodontal probing. That doesn't mean just a couple points and spot probing. So I'll give you some examples of how you can make that pop on your documentation. We also want to make sure that we're taking really good intraoral images. These have become more important in benefits considerations than it ever has in the past. I say the last 5 years, we've seen an emphasis on carriers asking for that information. We also, I've counseled lots of offices on how to get their claims paid. I have noticed that when I write an appeal or when I help them write an appeal, the presence of the intraoral images gets the point across much, much faster. So please, if that's not already in your workflow, I highly recommend that you get it in your workflow. For those of you who do crowns and crown buildups, which we're not going to cover tonight, you probably have noticed how important the intraoral camera images are for your records there. So the radiographs, I just want to tell you that the radiographs must be within 24 months. And that's a small little tweak that some of you will have to make, because, and the reason being is that most of the carriers, they are actually, the consultants who review the claims, they are actually not allowed to provide benefits based on imagery that's over 24 months. Now that's average. So I'm just going to say the standard is 24 months. So if you send in an x-ray that's 28 months and it's gorgeous and it's clear, it doesn't matter. That consultant can't actually approve benefits because the age of the supporting documentation is too old. Now, I have been told in lectures that there are plans out there that are asking for radiographs under 18 months. So that's something that I'm monitoring. And if you have a similar experience, I'd love to hear it and which carrier that is. So does that mean we need to have current radiographs? Absolutely. Just depends how current and what's your standard as well. So whether or not the benefits come, that's up to the patient's patient's benefits, but you need to decide clinically what's appropriate for your office. So here's a good example of a Perio probe. Now, for those of you, you're going to think, why is she showing me a Perio probe? I know what a Perio probe is, or a probing chart is. I know you do, but I want to call something to your attention. Do you see how it's super colorful? It pops, right? So here's another one. This is with the Voice Works that Florida Probe puts out, and that's really great because sometimes hygienists don't have anybody that can come in and help them. The reason I like this is because it does pop. It's got all of the colors on there. When I would audit charts, I would find periodontal probings where it's just pocket depths and not even bleeding. So we need to make sure we have all of that. Pus and separation. We need all of the clinical attachment loss. So we need that. So make sure that your charting is set to CAL, not just PD. That doesn't do anything. They need the clinical attachment level, loss. So you would need to make sure that that shows up on your charts. So go and look at your charts. Doctors, you may not have looked at your charts in a while because you've been on autopilot with this and everything's fine. That's okay. It's probably fine. 99% of you are going to find that it's fine. But the 1% is going to be surprised that you are only submitting probing depths and not even any bleeding, or there's no colors that are, different. My goal is to make your claims paid as easily as possible. And when it makes it so evident to the consulting reviewer, that's when your claim is going to get paid. Consulting reviewers don't like to wade through information, and I don't want to make them. I want to make it so super clear why that patient needed that treatment. So let's move on down here. This is the decision tree that Dr. Lau teaches in his classes, and if he ever wants to pop in, he's certainly welcome to. I know he's kind of sitting back and letting me drive the bus here, but what I wanted to call out on this is I would love for you to take this and go to your team and make sure that your team understands this protocol. For your insurance coordinators and billing managers who are not clinical at all, this is going to make sense. I know I've trained many of them where they didn't know this protocol at all and they would just wait to be told. Here they can't anticipate it. So let's just go quickly through here. Patient presents, they've got all that stuff on their teeth. It's gross, but we know it's gross too. It's just too much. You really can't do a comprehensive evaluation. It's impossible. So you send them over to a debridement, and that's what you would do. And we'll talk about that in a second. And then after there's healing, you send them back. Now, they may not need the debridement, so you just slide right in there to the evaluation, and we gave you the procedure codes that we're talking about on the side. Periodic evaluation, we all know that's when the regular appointments come in. So is it possible for a patient to come in and have a 4355 after being a regular patient? I would hope not, unless something has drastically changed clinically with that patient. So typically the debridement is going to happen when you have a new patient that you're helping to heal. And then depending on what they present, how they present the staging, you would see where they line up on here. And they could, of course, move down the continuum. It could happen. So if there is a inflammation and it's localized, of course, we've got the prophy, right? Now, if there is generalized swelling and gingival inflammation, then we're going to have the 4346. Now, the important point about that for my non-clinicals is that there is no bone loss when it comes to 4346. So when you send in the periodontal probings, they're not going to look odd. They're going to look like 3s and 4s, and therein is the problem, because the inflammation does not show up on radiographs, which is really why intraoral images help with the 4346. We'll get into that in a second. And then, of course, moving down to periodontal treatment, you've got the 4341, 4342, we've got the osseous surgery, and we're going to go into that more. So the debridement, let's look at this. The one thing I want to point out to you is that this is to be done without an evaluation. If you bill an evaluation the same day, it's actually going against what the code says, and most carriers will not cover it. What I find with some is that they'll cover the evaluation and not the 4355, and so that becomes a problem as well. What I always do with 4355 is I stop and I make sure that we have the conversation with the patient that it is not going to be a complimentary evaluation and prophy that day, that it is something totally different. The verbal skills behind that are very blunt and to the point because we don't want to sugarcoat it. This is a true condition that they're coming in with. You let them know that based on what you see in the mouth, we can't perform what we thought we were going to perform. I actually need to do this procedure to make sure that we get everything right with your mouth, you know, and you can make it your tone, but I don't want to sugarcoat this. So let's make it as blunt as possible because we need them to get the message. Do you know what I mean? So the quick FAQs around this is that will the deductible apply and will it be covered? So the deductible typically does apply. There are cases where it doesn't. So you should definitely warn the patient again that it's not going to be that free cleaning that they seem to think it is. And we all know too that that's not even free a lot of times. There's definitely some cost involved. And coverage, it is up to the individual plan. What you'll see often is that 4355 will be processed and then you'll get the benefits for a prophy, a 1110. So they may not benefit the 4355, they may slide it down to a 1110. And if that's the case, that's the patient's plan that's really deciding that. So let's move on to 4346. Now, BioLase actually has a coding guide for you, and we can talk about how you could get that later. But in my coding guide, I made a comment that 4346 is one of those that is a code that we love to hate. It's perfect for what we need. It really is, and it was created because of that. And if you take a look at the blue oval there, I wanted my non-clinicals to know what exactly generalized meant. So localized is one area, right? One location, one site that is a problem, is problematic. Generalized is when it is more than that. So more than 30% of the mouth involved, it then becomes generalized, right? Less than 30%, it's localized. So the generalized, moderate to severe inflammation, and again, no bone loss. So that becomes, so basically it's puffy gums. If there's something going on that's making it puffy, you'll see this with pregnant women a lot of times. And there's other clinical conditions as well. But this is something where they can go from a 4346 to a 1110. That's not a problem. Their condition could change, their medication could change, they could give birth, and then they go back down to having a healthy mouth. So it is possible to go from 1110 to 4346 and back and forth. Just depends on what the how the patient presents medically. So with this, the problem that I've seen with it is that there is no consistency on how it's benefited. So again, if you need to do it, make sure that you bill it. But this is one of those codes where I would definitely inform the patient that there is a possibility that it may not be covered, and you will be there to appeal it. I always want you to appeal because that's the customer service part of it. But there is a possibility that they may have to be involved and it may necessitate a call of the carrier. And by the way, with most of these procedures that we're going to go over, those are my talking points with the patient. When I come in to your operatory and I present the treatment plan with you and then the financial plan, what I will always say to them is we will try to get as much as we can covered by your plan. We will send in the documentation. There is a chance that your plan may not cover this procedure, and this procedure. I'm going to do as much as I can to get it appealed and to get the benefits, but if I need to, I may ask you to call either the carrier or the HR department of your company to see if maybe we can get some help there. So I prime the pump, right? So I make sure that they know that that's last ditch. Maybe that's not something that's going to happen, but if I don't want to surprise them by saying, hey, remember me 3 months ago? I've been appealing this. And by the way, can you call your HR department? Oh, you don't work there anymore? Uh-oh. So we need to make sure that we let the patient know that there could be issues with that claim. So when you get to the debridement part now, so this is definitive debridement. So what this means is you're taking a look at everything that is happening in the mouth, and you're looking at the progress of it. This again is one of those slides that I would definitely take to your non-clinical team members and let them know what's up. To be blunt, what's up. So you could let them know, you could customize this for yourself as well. You know, many dentists out there that you all know, you don't practice the same way. You have a set sort of guidelines, but some of you practice a little bit differently, different protocols and beliefs. So customize this for your team so that they know what page you're on. And then also making sure that's actually just good for me as your treatment presenter, because then I know what the next steps are. I'm not going to be surprised by you skipping a step here and making it up as you go along. And that really looks good to the patient, that you're all, you know, swimming in the same direction. And that's really, the patient wants to trust us, and I'm going to let them trust us by having that information. So let's move on here to the scaling and the root planing. And I know Sam's been having fun hanging out there, but a couple slides now, and I'm going to get him to perk up in here and you'll get to hear him. So some of you are like, where'd Sam go? So we'll get him in here. The 4341 and the 4342, so that's your scaling and root planing. Now we do have 1 to 3 teeth, the 4342. My issue with the 4342 has always been that it takes one of the frequencies from that quadrant from the 4341. As an example, you would bill for a 4342 in the upper left, right? So upper left area, you know, 1 to 2 teeth, right? So you would bill for that and they may benefit it. But what that means is, say a year later, that quadrant isn't any better and now it's spread through the whole quadrant. Then you would bill for 4341, and unfortunately, because you billed that a year ago, you're going to see that they'll deny that because they already had benefited the 4342. It's not wrong for the carrier to do that. That's their policy. That's what the employer selected. It's just, for me, it's a pain because now I have to explain to the patient that there's more out of cost involved. So we still want it from the patient. We still want to get paid for what we do, but it does add that extra conversation that we need to have. So 4342, not my favorite code to use, but it is there and it is useful, and it definitely is adequate in certain situations. So from the carrier point of view, typically you will see reimbursement 24 to 36 months is the frequency limitation. So what that means is if you do scaling root planing in one particular quad, then typically it's 24 months until you do another one, or even 36 months. And so you'll have to take a look at the plan and whether or not benefits would be allowed for it. Now, I noted something different. Now, I don't know if you caught it, but I said you're going to have to check the plan to see if benefits are going to be allowed for it. What I didn't say is I'm going to check the plan to see when we can do it. That's a very important distinction that many of us, if you're not thinking about it, it starts to creep in to our conversations with our patients. So don't say to them, well, we can do it when your insurance pays for it. Just try to catch yourself, because even the best well-intentioned clinician, sometimes we have it in the back of our minds, right? And so it comes out. Don't beat yourself up over it. If you find that you've been saying that, just start now, realizing that I want you to say, it might be benefited because it might not be benefited because we've done it within 24 months, or your insurance coordinator will say, well, it's been 24 months, so we may not be able to get it paid, but it's still necessary. I hope that you see the difference on that, and we certainly can go over that on Friday if that comes up in your FAQs, your Q&As. It's funny to call it Ask the Experts, but that is what it is, right? So what I'm seeing too, and Dr. Lau and I have talked about this at length, the carriers are changing the parameters for bone loss when it comes to getting your claims paid. You know, a long time ago, it was 3 to 5, 3 to 4, 3 to 5 was pretty common. And now we're starting to see 4 to 6 millimeters of bone loss required before any benefits are provided. So that's a conversation you're going to have with your patients if you are slightly more aggressive than that, and you do it before it gets to 6 millimeters. Have a conversation with your patient about why you do that. That way it helps me when I'm trying to collect and when I'm trying to get their help with getting the claims paid and appealed. It does always require periodontal charting and always requires clear radiographs labeled. I hope that you're all using electronic attachments to send in your claims. Right now, paper claims are being processed much slower. Electronic claims and electronic attachments are the way to go. Super, super easy. We're going to talk about narratives and how they're changing and why you are going to need to send electronic attachments in the future if you're not already doing it. So one quick comment here is that 4 quads in one day may be contractually denied, but I want you to appeal that. I've had some really good success appealing that if the doctor provides me with the correct information or helpful information. If a patient has a hard time getting in, mobility is an issue, caretaker is an issue, perhaps they have extenuating circumstances like their physician doesn't want them to stop taking their blood thinners. Whatever the conversation is, if the patient elects to do it, if you do 4 quads in one day, appeal that. I've had really good luck with that, and make sure in your notes, doctors, that it states why it's necessary and the fact that the patient agreed. So definitely we can talk about that on Friday, but I've been hearing more and more success stories about this because patients do come to us with a bevy of clinical issues. And if you document it, I can try to get you paid for it. So here's an example of why radiographs and intraoral images are both helpful, but together they present a very powerful image. So these are the same teeth. And when I send in just the radiographs for my scaling and root planing, I'm going to have a hard time with that. I may have to send in some extra information, make sure my perio chart pops with a lot of color, good clinical notes. But when I send it in with this intraoral image, I don't have to do much. This is a really good example of why it's different. So get in the habit of taking these intraoral images because, and it's something that insurance coordinators will say all the time, it's like gold. It really is like gold. We would love to have you give these to us all the time because we can do so much with it. So when it comes to lasers in dental hygiene, there is something called laser bacterial reduction for my non-clinical members. It's LBR. You'll hear your clinical team members say that pretty often, LBR. And now I'm going to ask Dr. Lau to comment on the bacteria and the diode laser energy because that's just above my pay grade. So if you wouldn't mind, Doctor.
Sure. There are a couple of procedures that are right down the dental hygienist alley, and that doesn't mean that a dentist couldn't do them, but laser bacterial reduction and laser-assisted periodontal therapy are two. For the LBR, the hypothesis is, well, first of all, diode lasers are going to be the device of choice. You could do it with Nd:YAG, but diode lasers, their chromophore, their target is basically going to be anything that is black or brown. And Porphyromonas gingivalis, which we consider to be the conductor of the microbiome dysbiosis, it is a black pigmented organism. So therefore, the laser bacterial reduction, that energy coming from your laser, and it should be uninitiated tip, generally for recommended settings, either 0.5 if it is going to be continuous, or around 1.5 watts average peak power if it's going to be from the standpoint of pulsed. So these organisms can be vaporized. Just to let you know, some of us are also using what we call photodynamics, in that we're putting hydrogen peroxide in the sulcus before we use the laser. In Europe, they use a lot of dyes to attract the laser energy, but LBR is definitely a definitive procedure that is done generally before you engage with your other procedures such as the debridement.
Great. Let's move on to the next one, and I'll go over the billing in just a second. There's also laser bacterial reduction, and that is, I'm sorry, that's exactly what he just talked about. I wanted to go over the rationale for it. For my non-clinical people, so what it does is it really just, it disinfects that area, and this is why your hygienists and doctors are coming to you saying, hey, I want to do this. We need to be able to bill for it because it is a procedure. And we're going, we have no idea what to do with this. So I just wanted my non-clinical people to understand exactly why we do it. It's fascinating when you're non-clinical to know about this. The fact that these bacteria can spread is just really fascinating and how quickly it can spread. And I mean, look at this. Look at that last bullet point for my non-clinicals. Done before periodontal probing to minimize the potential to inoculate the whole mouth with periodontal pathogens. What that means is as the clinician is probing the different pockets, they could be taking bacteria from an unhealthy site and putting it into a healthy site. And that's not what we want. So that's why the bacterial reduction is so important. Now let's move it. Oh, and here's an example of what you could use for that. I love this little thing. It's purple. There's also laser curettage and debridement. Now, Dr. Lau, if you could speak to that very quickly.
Sure. This is the second procedure that we definitely see in the dental hygiene operatory. No reason why it cannot be done in the dentist operatory. The caveat here, though, is always check with your board of dentistry to see what the laws are for dental hygienists as far as delegable duties. Sometimes you'll see, as an example, you can use the laser, but only for the procedures that you can do. And then you'll find a particular state that doesn't allow curettage. And so you just have to go and check. And if you check with us, we can tell you exactly what procedures. Now, I actually love this procedure and actually prefer this procedure if I had my choice between the two, because this procedure is literally curettage, anti-inflammatory, host modulation, because it goes in and not only removes the bacteria, but it also is going to degranulate the site and actually open up the site for more access before you do your manual instrumentation or your ultrasonic instrumentation. So I see where folks will use their laser after the debridement. No. You want to use the laser before the debridement so that you can create a little bit of an access path here to allow you to use your instrumentation.
Great. So here is the therapy. Now it's interesting. So let me just break it down for my non-clinicals. What you're doing is you're taking away some puffy piece, infected piece, and you're just getting rid of it. And that's the tissue. So it's not like big clumps of stuff, but you're getting rid of some of the tissue because it's so infected. It's not, you want to get rid of that so that the healing can happen. And so that's why this procedure has come around. And I know that there's more clinical reasons for it, but just wanted to break it down to a real simple explanation for you. So you would see here, actually, Dr. Lau, I'm not going to even attempt the pulse and the tips and all of that. Could you speak to that?
Sure. And again, we always say if you're going to do LBR, it's going to be uninitiated tip, because see, if you initiate the tip, then all the energy hits the tip and doesn't go deep into the pockets for the laser bacteria reduction. But if you initiate the tip, now you're getting, to a certain degree, some thermal reaction, and that thermal reaction is what you need for the curettage. So as an example, if you're doing laser bacteria reduction, you really only want the tip to go into the sulcus, the pocket, only about 1 millimeter. If you're doing laser curettage, there you want to have the tip start at the most coronal, but then move slowly and surely till it gets down to the bottom of the pocket. And as you said, Teresa, you're not going to see well, you could if it was highly inflamed, but you're not going to see substantial amounts of material come out of here. But it will literally remove the what we call the necrotic epithelial lining, getting into the good connective tissue, and then move forward if you're going to get any kind of attachment.
Thank you for that. So here's a visualization for you. I'm going to actually let you talk on this. So I apologize for making you talk so much, but I think you're going to do a better job with this than I will.
Oh, no. You're doing very well. I mean, your first part of this was right on target from a dentist perspective. So this is just diagrammatically showing over on the left, you're seeing the organisms that are in the tissues and also the organisms that possibly could be in the sulcular, in the microbiome. Here's your laser energy going in. The laser energy is not only looking for the organisms, but you can see that it has removed the epithelium from the area, now giving us a connective tissue and then moving forward. Now, most of the time, to be realistic, and this is the periodontist in me, this is going to be a long junctional epithelium. However, if you were to remove the smear layer, then you get more of a attachment that we consider to be a connective tissue attachment. I would mention that, and no, you can go forward. I would mention that when we do look at this, and I will have Teresa take a look for you as far as the codes, that average-wise, about most practices do anywhere from $30 to $40 for a full mouth for laser bacterial reduction, and many practices charge $50 a quadrant when they're doing the laser-assisted periodontal therapy.
So what code are we going to use though? Well, we've got really no other choice but $49.99. There is no code that adequately describes it. I have read and researched and tried, and I just can't make it work. So really $49.99 is the only one that I can recommend. That's what Dr. Lau and his group has been recommending for a while. Unfortunately, $49.99, any of the 99 codes are always going to be subject to review, usually requires a report, which from an insurance coordinator point of view, we'll write the report, we'll take the clinical record, but we really don't have a lot of hope of getting it paid. 999 codes are notoriously not covered, even with a report. So when you say 999 to an insurance coordinator, you can see that they just die a little bit inside because it's going to be a hard time getting that paid. So they will also, the carriers will also indicate that it's part of another procedure. Now, I know that this is going to be something that we're going to have a lot of questions on Friday. So I just want to preface that I am going to tackle this part because it is one of my most frequently asked questions. Many offices do use a form, a HIPAA release form that that allows you to not bill the insurance carrier for that particular procedure, and the patient would pay for that out of pocket to you. So one caveat, in case you're not able to come in for Friday, one caveat is this: I don't want you to use this as an abusive form. I have definitely seen it being abused. I've seen offices having patients sign this for pretty much everything, and that's not the spirit of the form. What this form does is basically allows you to not bill, right? So when that happens, what you're basically saying to the patient is, please sign this form so that you can pay out of pocket for it. And that's what we want, but it's a very delicate conversation. So let's definitely talk about that on Friday. But that is an option that many offices use. And of course, if you're out of network, that's not anything that you have to worry about. So that's another pro to being out of network, is you don't have to worry about doing any appeals and having these difficult conversations in any HIPAA forms being used really not for its intended use. So let's go back to Dr. Lau examining. We have a series of slides here where he's going to move us through, and we're going to get into another set of periodontal procedures as he talks.
So the next, what we call swim lane, which I'm highly encouraging, periodontists know this, but as Teresa mentioned about that large group of moderate periodontitis, let's move into what is considered to be the next level, which would be surgical. So here you see our curettage. Here you see the flap procedure. And so you may be aware that we are moving with lasers into a hybrid of a mini flap type procedure, very mini flap, to be able to allow ourselves for reimbursement and still be within the guidelines of the ADA-CDD codes. So if we could move forward, Teresa. So it's really more than just the curettage aspect, it's a mini flap. So as we move forward and we discuss osseous surgery, I just want to, one of the great things about having Teresa and I both is that we're giving you a perspective from both sides. So let's take a look at, if you're going to do laser procedures and you're going to utilize them for this code, I highly, highly recommend that you have got to do at least some type of small mini flap to be able to see the osseous, see the root, so that you can satisfy this. Because if you don't do that, you're not going to satisfy the descriptors here. So Teresa, that was my primary interest in having a conversation relative to the D4260.
So just to add to that, so you must, according to the code, if you're going to use this particular code, you must have augmented or removed some bone. So if your clinical record doesn't state that, and again, the information with the elevation of a full thickness flap and the closure, if you don't indicate that in your clinical record, then I have to side with the carrier on this, and there isn't the availability for benefits because you don't have the proof of it. Now, that doesn't mean that you didn't do it, but many of you have taken classes on how to document and malpractice classes and all of that. This is directly tied to it. I want you to make sure your records are as complete as possible. So one thing that I want you to make sure when you do this is that the radiographs are current, your periodontal probing is current, because all of that together, along with your clinical record, it's going to be a much stronger case. And as your insurance coordinator, I'm going to have a much easier time getting this covered. So many times you'll see this particular code being sent down to or being paid at the 4341 rate, which is a little bit lower. And that's, again, part of the conversation that you'll need to have with the patient, that we're going to try everything we can to get this paid. I just want you to know that we may need some help in the future with this. So if I give you a call, that's what that's about. So again, make sure that you have that all set up. That third bullet point is really important. So some of the carriers will actually say, in order to benefit this, we need to have a history of scaling and root planing the 4341 or 4342. Every time I've appealed that on behalf of an office, we've been able to get that covered because the clinical record during the comprehensive evaluation or the periodontal evaluation, there was enough noted and documented that showed that this patient, we didn't need to go down the continuum. Osteosurgery was the correct method to treat their condition. And so without that clinical record, though, I don't have it. So here is the repair Perio protocol. And Dr. Lau, if you just want to expand on what this is, I know that this is, they love this.
There's several laser protocols out there. This is one with the particular erbium chromium YSGG laser. And so you can just see that we are literally removing epithelium on the outside, possibly doing a gingivectomy. If you go to the next one, Teresa, it really is, again, when you're actually reflecting the flap with the laser. When we say full thickness, now there's a difference. There's a flap and a flap. A mini flap can still be full thickness and be right at the crest of the osseous, the bone. A full thickness flap can also be all the way past the mucogingival junction. So we're not suggesting the latter. We're not suggesting you're doing this completely a flap past the mucogingival junction for laser. It is a mini invasive procedure. We're just suggesting be careful, do what the descriptor says, and see the bone and see the root. And also, as you said, Teresa, also augment, either do some decortication or augment, primarily recontouring the osseous, and really do it. Thank you for saying that. Don't just put it in your notes, you got to really do it. So what I am suggesting is probably in periodontal surgery with laser, there's no use to really even use 4240, 4241, because if you're doing periodontal surgery in the first place, I would imagine 99% of the time you're going to be doing something with the osseous, or I'm going to be asking you why you're doing the flap in the first place.
And it's actually comforting to me to hear that, because 4240 and 4241 are really hard codes to get covered. So
codes, and not that we want to, yeah, but we are colleagues and clinicians. The reimbursement on these are really not fit for how much work it takes. So just doing some more osseous absolutely justifies what you're doing.
Perfect. Okay, so I'm going to call out some of these items, and I know this is the list that BioLays provides with all of their documentation, and in the billing and coding guide, we also have this. There's a couple things that I would like to add, and so we'll go through this. If you are doing these procedures, this is a perfect template to create, and if you already have templates set, just compare this and add in what you need to. I just want to preface it by saying that I would love for you to get in the habit of adding the two entries, time seated and time dismissed. That really is more of an overall coding issue. I am definitely seeing some issues with anesthesia and also with certain procedures where they're asking how long the patient was in the chair, especially for scaling and root planing. If you have ever received a letter asking for a copy of the schedule, the reason is that your numbers when the carriers ran it, it looks like you're doing more than you actually are. And by having time seated and time dismissed already in your clinical record, then you already have protected against that. Is that something that you should expect to have requested from you all of the time? No. In my experience, when the carrier is asking for a copy of the schedule, in my experience, that usually means that you're on some sort of a watch list. And I can certainly talk to you privately about that if you kind of just went, oh no. So look at all of these bullet points here. You've got so much that you need to write down. I'm not going to go through every single one of them. Many of them are very clear. You can see exactly what I'm talking about. Now, one thing that I learned when I first started having conversations with Dr. Lau about lasers is the importance of the laser setting. So making sure that you have that in there and that you make sure that you fill that out completely. If you just have it in there and you kind of skip that, that's not very helpful at all. I want to make sure that that's put in there just in case you ever are questioned about it. The one issue that I would really love from a practice management and protective mode, because my job is to protect the office, right? As the office manager, I want you to make sure that you have in there any patient comments, you know, like patient states, this is sensitive, patient states, everything felt fine, patient states, any of these patient states conversations, I want you to have those in there, especially when you're doing the follow-up evaluations. I want you to make sure that you have patient states, they're happy, patient state sensitivity is going away, all of that stuff. But also the post-op operative instructions, make sure that you state that you went over those. Don't just hand them a piece of paper and say that you did. I want you to give them whatever paper you have, verbally give them the instructions, and then I want you to note in the chart that the patient acknowledged that they received that. And of course you're going to do that. So in your chart, I would love to see patient understands post-operative instructions. That's just going to help you out. I always want to protect my doctors from any kind of legalities that could come at them. Dr. Lau, anything extra about this slide before I move on?
No, it's and I appreciate about the laser settings. No, this looks great. I know it seems like a lot, but it does justify what you did.
Absolutely. Okay, so let's get into the gingivectomies and the gingivoplasties. So for my non-clinicals out there, I want you to think about the word contiguous, because that is the big decision that they have to, that the clinicians have to pay attention to, because that's what differentiates these codes. Now, it's an interesting procedure because it is typically, and I'm not talking clinically or needs here, I'm talking from a billing point of view. This is typically bundled up, or it seems to be bundled up with other procedures. So it's very hard to get reimbursement for this procedure code when you do it. But again, if I have my documentation, it's going to be a better road. My advice to you, if you're a newer insurance coordinator and you've already been seeing this get bundled up, my advice to you is to attempt to appeal it. Go ahead and try. A good insurance coordinator starts feeling the boundaries. We're kind of like, you know, precocious kids. We feel the boundaries when we do our appeals. And that's how a good insurance coordinator learns. So go ahead and make an appeal on this, and you'll see that some of them 50-50, some of them you'll be able to get covered, or at least you'll get a corrected EOB that states that it doesn't need to be written off because it is a separate procedure. So if you're in network, what's very frustrating is your clinician will do this procedure and then you're required to write it off. That's very frustrating. If you're out of network, you really don't need to worry about that, which is really nice. Now, here's a small, I mean, look at this code. You don't use it very much, but it's one tooth, right? So if your doctor's only working on one area, this may come to pass. Now, I don't actually see this too often. Dr. Lau, how often do we see this clinically?
As far as the procedure?
Having to do this procedure with just one tooth involved.
Well, especially around the class 5 scenarios, which this is. So with the class 5s, you will see that. We're going to move forward here with, I mean, it is, and you will speak to this, there is a little bit of complexity here on what code you use. But here, one tooth, and here we're doing just a little gingivectomy to be able to get restorative access. But every now and then on class 5, you will see it.
So this is where we're going to go with this, and I apologize if you had little children around. I probably should have warned you. But here are examples of anatomical crown exposures and crown lengthenings. So for those of you who are non-clinical, when your doctor has to do an anatomical crown exposure, it's because there's a really excessively, what we call a gummy smile, and that's typically where you'll see that. And so then we move on to the crown lengthening, and anytime you want to pop in, Dr. Lau, you can. The clinical crown lengthening is what you will see done most often. However, some carriers, especially the anatomical, this one, the anatomical crown exposure, this is usually seen as aesthetic. I have not great success with getting this covered if I need to appeal it. The crown lengthening is a little bit easier to get covered, but I definitely can't do it without really good documentation.
Yes,
So,
because also the descriptor here also talks about osseous. And so I would highly recommend that your 4249, including even with aesthetic crown lengthening, but especially that one tooth crown lengthening where you're just really difficult trying to get biologic width, this is the code that I prefer.
So for my non-clinical people out there, what this does is it actually removes some of that hard tissue, and it basically makes it so that we can fit a crown up there. There's not enough exposed root structure in order to have a crown ideally sit on there, and so that's why your clinician would have to do it. You know, if you ever get a chance, my non-clinicals, if you ever get a chance and they're doing this procedure back there, hop back there, get gowned up, scrubbed up, whatever. Some of the most fun I've had is learning these procedures by just watching. It's much easier than having to assist through them, which I've had to do. If you're just observing, much, much easier. So, and if you're working with a periodontist or a specialist office, I've never met a periodontist that isn't open to having team members of their referring offices come and observe these procedures. So honestly, why not? So in this situation, I believe this is a crown lengthening, Sam, or Dr. Lau. Sorry, I believe this is a crown.
It is. It's the classic crown lengthening, including osseous. So it does satisfy the descriptor. And what a powerful procedure. Wow factor. This is even without any restorative, without any veneers. And the healing is exceptional when you use the, especially like an erbium all tissue laser. It works very well.
So let's go on here. I know that we're getting close to the end of our presentation, so I want to kind of wrap this up. And if I miss anything, I definitely will add it on to the next one that we'll do. So make sure that your documentation shows all of this. I want to just preface again that the carriers do see this as cosmetic, so you're going to have to make some documentation or at least prepare the patient. So here is the Perio Protocol. Again, make sure that it's matching your templates for your clinical notes. These are all of the codes that could be involved with the protocol that we've been going over, all these procedures. So these are available to you, and many times clinicians seem to get stuck with the same couple codes. I've noticed that, and reach out a little bit and see if you're actually doing procedures that you weren't aware you were doing. So let's talk about this one, which is not necessarily periodontally involved. It's not a disease, but it is something that happens very often in the hygiene chair, and that's when someone comes in with a herpetic lesion, an abscess ulcer. I can never say that correctly, but the laser can be used to disinfect it and destroy the lesion. Is that correct, Dr. Lau?
Yes.
Okay.
Yes, yes, it's antimicrobial or antiviral. Another great wow procedure when patients come in with discomfort.
Yes. If you have someone who suffers from this, believe me, they are super happy that you offer this service. So definitely explore that. If your hygienist is a little nervous with using the laser, this is something good to kind of get them into it because it really does make a big difference. So just real quickly, it just kills the nerve endings, gets rid of that. It kills the surface virus. And it's really important for your clinician too, because when there's an active lesion, we don't want that in the air. And so we want to make sure that we take care of that as much as possible. You may find that your clinician is rescheduling anybody who has an active lesion and they don't have a laser there because of the danger of that. So that is something that's really fascinating to me. So I'm going to wrap this up by telling you that there's a new way of sending in your documentation, newish. I've been testing this with a lot of offices, and I am confident in saying that instead of writing a narrative, what the the carriers are asking for is an actual screenshot of your clinical record. Remember how I started off saying documentation now more than ever? This is a really good time for you to take a look at your templates, take a look at your documentation, and make sure it's a very complete picture of what you did. Because me, as your insurance coordinator, if I can just screenshot your clinical record, screenshot your perio charting, screenshot your intro images and your radiographs, I can get your claims paid faster and I can get them out the door faster. My job, which is very time consuming, gets a lot faster. So please make sure that you can get that settled. Sometime soon it will pay off in dividends. So I know that we went right up to the hour, and I know that we usually have questions, but I will answer some questions. I don't want to leave you all hanging, but I do apologize for those that we went right up to the hour. I do hope that you'll join us on Friday.